Good afternoon, CNY Nation. I'm Dr. Randy Fink, and we are live from Colorado Springs, Colorado. Fertility with Fink and Friends. So happy to have you all with us here. It's just a little bit after 4 o'clock on the Mountain Time. Looks like everybody's joining. Hi, Janine and Tina Marie. Oh gosh, Katie. We've got Alexis and hello to my dear friends in Miami. Hi, D. Hodge, and nice to see everybody with us here. Well, gosh, it's. I hope you can hear me okay. If you can't, please do say something on the messages there because we're trying a new little microphone thing here, and hopefully it's working out. So 3 minutes after 4 o'clock on the Mountain Time, which means just a little after 6 o'clock on the East Coast. I am the clinical director of IVF services here at Colorado Springs CNY Fertility and the medical director of CNY Fertility at the Miami Center of Excellence. So we are here today to talk about all things fertility as well as all your questions and answers and things about women's health. Anything I can do. Hola, hola, Lady Glory. Nice to see you. And everybody else who is with us here on this Tuesday afternoon. Thanks to all you folks who joined me on Sunday morning. I sat in for Fireside Fertility with Fink, sat in for Dr. Kiltz, and it was good to actually get up on a Sunday morning and do something productive. So glad to be around here. Well, let's start out with some questions. If we can, and I've got a couple of other topics hopefully we'll have a chance to cover today. But I saw a question here from Jontel. Oh gosh, I think that says Jontel Share Photography. Glad to have you with us here. We've got, by the way, we've got Facebook and Instagram. Hi, Erica is with me there on the Facebook side. We've got Facebook, YouTube over there. We've got a couple of different Instagram feeds. And just happy to have everybody with us here, and hopefully we can have a good time. So Jontel says a premature ovarian failure, and let's talk a little bit about that too, because that's a term that's thrown around a bit. People say it. I want everybody to understand what that means. Premature ovarian failure or premature ovarian insufficiency is when basically the ovaries will shut down before, typically considered technically before the age of 35. So when that is usually thought to be, so basically a menopausal level of hormones that's thought to be due to some autoimmune reason. Usually it's something where the immune system has affected the ovaries and causes them to stop functioning in the way that they're supposed to. Typically, with premature ovarian failure, our best choice is to go with a donor egg at that point, because it means that essentially there are no more eggs in the ovaries. Now, I have had patients here at CNY in whom we've tried a variety of different things to see if we could get the ovary to function. We've tried intra-ovarian PRP, and certainly a number of the supplements that we recommend to try to get the ovaries to function. But in general, the odds are pretty low that we can get an ovary to respond for IVF with your own egg once it reaches that menopausal level. But in any event, Jontel says premature ovarian failure, POF, matched with a donor, waiting for her cycle day 1 and retrieval. And that's fantastic. What protocol do you suggest for someone who doesn't ovulate and doesn't produce eggs? Well, so I think what you're asking there is what's the best way to, once we've made an embryo, to be able to put the embryo back inside of you? Well, so normally when we do a frozen embryo transfer cycle, we have two different options. We have a medicated cycle and we have a natural cycle. And Jontel, since you don't function naturally, obviously we're not going to do a natural cycle FET. So the medicated cycle has been around since IVF was invented, and it is still really what we do with probably 90% of our cycles. I just today made a video and sent to our PR folks about that modified natural and the natural cycle, which is going to be going up as soon as they edit it onto the CNY Instagram side. So talking about that a little bit. But so what we'll be doing for you, Jontel, is a medicated cycle. So it's typically 6 to 12 days of estrogen in order to thicken up the uterine lining so that it makes for a nice baby blanket, a nice place for the embryo to implant, followed by typically 6.5 days of progesterone injections. That's progesterone and oil, usually also accompanied by some progesterone vaginal suppositories as well. That is the meat and potatoes of a medicated cycle, or as I like to say, that's the cake. But we do put some icing on the cake as well. The icing on the cake are our immune protocols, typically either a level 2 or a level 3 for most people. And with your history of premature ovarian failure, I'm going to say I would recommend an immune protocol level 3 for you. And you can look at our family building guide. It sort of lists out what all is on that immune protocol and gives you some more information on it. So that's what I think I would do for you. There are a group of supplements that we recommend for specifically for embryo transfer. Now, if you've heard me talk before about the supplements, what we've done here is basically reviewed the book, which is It Starts with the Egg, which is kind of the quintessential book on the issue of egg quality, and how we can biochemically change things in our bodies through supplements in order to make changes, and to positively affect things like egg quality and diminished ovarian reserve, sperm quality, so for male factor, and for embryo transfer as well. The supplements that I recommend for embryo transfer are: 1, a prenatal vitamin; 2, the one that almost everybody forgets that there's pretty good evidence on for embryo transfer is L-arginine. Number 3 is vitamin D, and I always recommend the liquid vitamin D because it's better absorbed. We put that vitamin D, D3, with vitamin K2, which does some other very good stuff for us, particularly cardiovascularly. Some vitamin E, and some fish oil. So I don't think I'm missing anything there. Vitamin E, prenatal, L-arginine. If you'd like that protocol, just Instagram me, and I'm happy to send you the list. If you Instagram me and I didn't answer yet, I promise you I will. I just kind of get a little behind on those. I did a few of them yesterday, and so my apologies for the delays on that. So best of luck, Jontel. That's so exciting that you got your donor. Can't wait to see you pregnant. Let's see what else we have here. Oh no, somebody's not hearing me. Well, let's see. Let's try this and see if you can hear. So it looks like my Facebook side, or rather my Instagram side here, wasn't working. So hopefully it is now. If somebody could just message me and tell me if that's working or not. And hopefully that means that the Instagram side on the CNY part does seem to be working. So, well, we only have 3 people left over here on Instagram. Oh, we got it. Okay, thank you. Alexis is watching me in Miami. Alexis is a superstar nurse practitioner in our Miami office. So thanks for being with us. So we were just talking about, well, you know what? You can watch it again over there. Everybody else saw it. So we'll move on now. Gosh, that's so irritating that I've been talking for the last 11 minutes and nobody has heard it. But so let's see if we can't get some questions from over here. We've got, how do we determine what embryos to transfer if we're choosing not to PGT test? So good question. So basically, and hi, Kid, nice to see you there. Basically what we do is that when the embryologist will kind of take a look at our embryos and really just kind of pick what are which one is the prettiest, which one is the best looking, and that's how we make the decision of what embryos to go in. Now, what does that mean? Does a good-looking embryo actually correlate with any kind of outcome? And the answer to there is nah, not really, because you can have an absolutely beautiful embryo that has complex chromosomal abnormalities, while you also have a less well-graded embryo or an uglier embryo that turns out to be the one in the group that's normal. So what do you do about that? Well, we have to have some criteria someplace in order to pick an embryo. So they'll just kind of pick the best looking ones. The idea of embryo grading was originally, they originally came up with that to say, can we look at an embryo and tell which ones are normal based on some criteria by what they look like, physically looking at them or under the microscope? And the answer to that is no. No, PGT testing is the one pre-implantation genetic testing for aneuploidy, PGTA, which will tell us if they are chromosomally normal or if they're believed to be chromosomally normal. And that's not a perfect system either. So there are many situations where I wouldn't recommend PGT testing for you. But when we have a PGT tested normal embryo, then we know that that embryo has about a 60% chance of a pregnancy, and generally speaking, about a 50% chance of ongoing pregnancy and live birth. So the best results that we can hope for with IVF are with a tested normal embryo. But if we don't do the testing, really what we can do is just kind of pick the best looking, and that's how we decide what to go in. So let's see. Okay, and thanks for the information about the sound there. I appreciate it, Lauren. Thanks for letting me know. Okay, let's see. We got some questions on the Facebook side, and we got a whole bunch of them there. Hallie says, hoping to see you later this week for retrieval. Can't wait. Victoria said, I had my emergency C-section on April the 6th. With a CNY Colorado baby. She's doing great now, so I'm so happy to hear that, Victoria. That's awesome. My question is that when they did it, my OB was concerned about how extremely thin my uterus was. She says it was as thin as paper. Will this cause issues in the future for me to do another transfer? Generally speaking, not. So first thing is, Victoria, congratulations. We are so happy for you to have had your baby. Gosh, having to have that C-section on an urgent basis is such a stressful thing, but at least we know that you take home a healthy baby, so it absolutely was the right choice there. What happens is that when we're in labor, or as we approach the time of labor, sometimes it doesn't even require the contractions of labor to thin out the wall of the uterus, particularly the portion that we call the lower uterine segment. And that's generally kind of what is just right above where the cervix is on the uterus. That's the point at which we make an incision on the uterus in order to deliver the baby when you're having a C-section. So it's very, very common that that area will thin. It can become really paper thin. Sometimes we go in to do a C-section and gosh, there's just one cell layer left. And so we think, oh my God, we are so close here. This uterus could have just ruptured and it could have just opened right up. Oh, what a terrible threat. However, we sew that lining, we sew that uterine wall back closed again. So, and then once it heals, the muscle thickens up there as well. Now, the fact that that uterus has a scar on it is the reason that there are concerns over doing what's called a VBAC. VBAC is vaginal birth after cesarean, or some people will call it a TOLAC, T-O-L-A-C, which is a trial of labor after a cesarean. And so the concern there is that if there's some weakening in the wall of the uterus, then when labor comes and that uterus contracts in order to try to deliver the baby, that there is some risk in that scar dehiscing or opening up. And so that's why there are some very stringent guidelines on how we handle trials of labor after cesarean or people who would like to do a VBAC. The hospitals often have very strict rules about where the doctor has to be in order to the doctor may have to be in-house, or they may have to have coverage in-house close by, be immediately available for an emergency C-section if that need arose. And that's also the reason why many doctors won't do trials of labor after cesarean, because they feel like the risk is too high, or as it may be that the liability itself is too high, that someone is going to sue them if things don't go the way they're supposed to. So many obstetricians won't do it. But that's about the thinned lower uterine segment, very common in labor. And Victoria, gosh, we're so happy for you and glad that you brought your baby home. Thoughts about Viagra for a female? Well, so Viagra we use in IVF to help the blood flow that goes to the uterus. It particularly can help to thicken up a lining in a medicated cycle in someone whose lining is not getting thick enough. Now, you may remember, or you may know, that we want your lining to be about 7 millimeters at the time of what we call your progesterone clearance. So 7 millimeters is the minimal thickness that we want of the endometrium. And if it's not thickening up, typically we'll add some more oral estrogen. We can add some more vaginal estrogen. We can add Viagra, and we can add also there's an injectable form of estrogen that's called delestrogen. So in that manner, Viagra is actually very helpful. Some people ask about Viagra for libido, and really the evidence for sex drive, Viagra for sex drive for women, is not very strong. There are probably some other really good things that we can do. Viagra may increase some of the blood flow to the genitals, and so it may have the ability to improve orgasmic response, but as far as libido itself, probably not so much. Whereas in a man, it's kind of a different story. If his erection is stronger, then he typically is going to have a desire to use it. He's going to have more libido. So that's why Viagra works for libido in men, but it is clearly more of a complicated scenario in women. So hopefully that helps there, Ciara. Is a trilaminar lining a must for a day 3 transfer? What's the optimal lining? So basically, Angelina, a trilaminar lining means that we are seeing the top layer of the uterus, the bottom layer of the endometrium, so I should say top layer of the endometrium, the bottom layer of the endometrium, and the interface between them where they sit on top of one another. So if you're looking at my hands right now, this is trilaminar, layer 1, layer 2, and then that line between them, that's trilaminar. And what that means is that it is, indicative of it being adequately estrogenized. So hopefully that's a helpful thing there. H. Rosendale on my Instagram side there, thanks for being with us, is a small 1 centimeter submucosal fibroid in the anterior wall an issue? And I would say the answer to that is yes. A submucosal fibroid means that a fibroid's a ball of muscle, and balls of muscle themselves are not inherently pathological. And by that I mean that 70% of women have fibroids. 70%, 7 out of 10 women have some evidence of fibroids. And what happens with a fibroid is that, as you can imagine, the uterus is made of muscle, right? And the job of that muscle is to squeeze the baby out when that time comes. So as these cells come together, they form a little sheet. They form sheets, and that's what makes that little hollow organ that is the uterus. Well, sometimes as these sheets come together, one of the little cells will get knocked off kilter, and that's what forms a fibroid. It is literally a ball of muscle. So, as some patients are fond of telling me, they have balls. Oh, yes, they do. And I've got ultrasound pictures to prove it. That's what a fibroid is. It's a ball of muscle. Now, there's different kinds of fibroids, and fibroids themselves don't, in fact, necessarily cause problems, but sometimes they can. A fibroid can be within the muscle of the uterus, and that's called an intramural fibroid. Inside the mural, the wall, inside the wall of the uterus. And typically, those intramural fibroids don't cause any issue really at all. You can have what's called a subserosal fibroid, and that's a fibroid that's more on the outside part of the uterus, that's sitting out here, sort of more in the abdominal cavity, and that one typically for fertility doesn't cause a difficult time in getting pregnant either. But a submucosal fibroid or an intracavitary fibroid is taking up valuable real estate where an embryo wants to implant. Now, if you told me a 1 centimeter intramural fibroid, I would tell you forget about it. First of all, it's very impressive that they saw that thing anyway by ultrasound. But H. Rosendale, if you've got even a 1 centimeter fibroid that's occupying space inside the uterine cavity, we want to remove that fibroid because we don't want it. We want we're going to a lot of trouble here to make a beautiful, perfect little embryo, right? So we want the space where that embryo is going to grow up to be just as beautiful and just as perfect. So taking out a 1 centimeter fibroid, submucosal fibroid, is a very straightforward and easy surgery to do now hysteroscopically. It's done through the vagina, through the cervix, with a little instrument that kind of acts like a Pac-Man. And it makes that noise too. And it eats the fibroid. It just goes, choop, 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 and the fibroid's gone, and the problem is solved. So for sure, I would recommend that you get that looked at. Damari is here on the Facebook side. Howdy. I got a call today from the genetic test lab, and all my embryos are abnormal. Oh, gosh, that is so frustrating. I'm 41. Do you think I should do an egg retrieval again? Well, I will tell you that my guess is eventually, Damari, you are going to be able to produce a normal egg that's going to make a normal embryo. If we play the laws of physics here, IVF is a numbers game, and if we just keep doing what we know how to do, eventually you probably will produce a normal egg, and you will be able to make a normal embryo. The question is, how long is it going to take? And that's always the issue. Is it, are we going to be able to do it? Is it going to be next cycle? Is it going to take 2 more cycles? How long can you continue, to afford it, both financially and really more importantly, emotionally? Because the finance part at CNY, this company really tries to make it easy for you with the lowest cost IVF in the country and the financing options. We really try to make this something that everybody has the ability to do. But, it's the emotional cost that's really a big thing that gosh, I just have to say, how long can you keep doing it? And you're the best one to answer that question. I do think that if you kept doing it, you're going to get what you want, just given the fact that we're playing the numbers. You put enough quarters into the slot machine, eventually all those things line up and it pays something out to you. Now, is it going to pay off the big major jackpot where you're going to get, the $28,000, or is it going to give you, a handful of quarters? Well, you don't know that, but my answer is, yeah, I do think it will work for you, but there's some things that you want to do to maximize your egg quality. And this really goes for everybody who's undergoing IVF. Number one, do everything that you can biochemically to improve your eggs. And that is the supplements that we talked about before. I'm a big believer. They do make a difference. They do change things. They do work. Secondly, in your situation, I would probably, Damari, use some omnitrope. Omnitrope is human growth hormone, and growth hormone is what keeps us young. It gives us the ability to help to repair some of the age-damaged DNA. So I would certainly prime. I would do everything I could for egg quality before doing another retrieval. But yes, I would do another retrieval. Now, it might be a different story if you were 45, because the odds of being successful with your own egg at 45 in IVF are very, very low. But at 41, it is absolutely plausible and happens here at CNY every single day. Um, my friend Kia Lene says, and I always apologize because I'm not sure I'm pronouncing it correctly, scheduled for my transfer Monday in Syracuse. The nurse did say my LH is rising. Will that affect anything with my transfer? Well, it can. So the LH surges when you are going to ovulate, right? So what that means is, depending on what kind of cycle you're doing, if you're doing a natural cycle, then we want you to ovulate, because when your ovary releases the egg, you're making your own progesterone, and that's all, generally speaking, a good thing. So what that would tell me is, gosh, I want to know kind of what's going on the inside there, and it may affect the timing of your transfer. Now, some people ovulate through and the timing is just all wrong, and we can't get you there, you can't get there in time to get the embryo placed inside. And if that's the situation, then maybe you change things over, but hopefully we can let that ovulation work to our advantage. Let's see. Looks like Chelsea Horan says, curious about adding naltrexone to a protocol per CNY's post last week. So, low-dose naltrexone is a medication that is on our immune protocols. It's actually on. It starts with the level 2 protocol. So, just about everybody gets prescribed low-dose naltrexone, unless for some reason you're doing immune protocol 1. Low-dose naltrexone is a low dose of naltrexone. You like that? That's very clever. I am here. Naltrexone is a medication that in higher doses can block certain receptors in the brain, opiate receptors in the brain. In low doses, what it does is that it stimulates our level of endorphins. Endorphins are a good thing. Endorphins are what we feel after, it's the runner's high, classically. That's endorphins. When a woman has a baby, and let's say without, best example, and it's an unbelievable scenario if you've never seen it, especially someone who is doing it without an epidural. And I would say if you have thought about having a baby without an epidural, more power to you, but it is something that you have to prepare for. It's not just a choice that you make and say, yeah, I'm not going to have an epidural. In all probability, that means you'll be getting an epidural, because unless you're really prepared for what's going to come, that you've really trained for that marathon that is labor and delivery, it may be an awful lot to handle when knowing that relief is in sight just for the asking. But if you're prepared for it, absolutely doable. Women can be in the throes of agony associated with labor, and then the baby comes out, and there is this calmness that happens. That's just, honestly, it's unbelievable how quickly the body recovers, and that is because of endorphin. And so low-dose naltrexone increases our production of endorphin, which helps us with egg quality. It helps with fertility. It helps with implantation. It helps with everything that's good in the body. So that's what low-dose naltrexone is for. It has to be compounded. This is not something that you can just kind of pick up from CVS or Walgreens. It has to be made for you. But in the anti-aging community, we know that low-dose naltrexone is used for wellness. It has such a profound effect on the immune system that people who take it, you never get a cold. It was kind of a big thing during COVID that people swore that they would prevent them from getting COVID. But certainly it's true that it keeps you from getting, common illnesses that your kids bring home from school or that you pick up, when you're walking through the grocery. So low-dose naltrexone is a good thing. And Chelsea, that will, in all probability, be included from you. Zaza Balloon says, I am just in my diagnostic month. I start my keto fertility diet today and my molecular supplements and having my blood work tests next week. Well, that is very exciting. The diagnostic month is typically what we do before we begin the process of fertility treatments. And that's when we line everything up in terms of the blood tests and the imaging. Some folks will do an HSG during that time. Others just a saline sonogram. I do feel like the cavity evaluation, Zaza, is very, very important for anyone who's planning to undergo a fertility treatment because we want to know that that lining on the inside is normal. This is something that is often overlooked by folks, that they may think, well, I did an HSG and that showed that my lining was normal, or that I had a pelvic ultrasound and my lining looked fine there. But in reality, unless we place a little fluid on the inside, either with the camera, the hysteroscope looking directly, or with a saline sonogram, so that's a teaspoon of fluid that goes in while we're doing a vaginal ultrasound, in order to separate the top and the bottom walls of the uterus, that shows us that the cavity is normal. So good luck there, Zaza. And let's see what else we have here. There's my friend Sally from Trinidad. Should an IUI be done with an 18 millimeter follicle measurement, or should it be 20 millimeters? Well, I have always triggered folks for IUI at an 18 millimeter follicle. So what we're talking about there is that we measure, of course, the size of the follicle in the ovary. And the follicle is the egg house. How big is it? And it's based on that size that we determine whether it is mature or not, because we want the egg to come out as a mature egg when the body's going to release it. Now, we usually use a trigger with IUI, or intrauterine insemination, because we want the ovary to release that egg in a predictable fashion so that we can maximize the possibility of sperm meeting egg. So typically you do the trigger, and usually about 36 hours later or so, you do your IUI. Now, what does the data show us about that? Well, in fact, that number is sort of it's a convention. It's something that we've always done, but the data actually shows that kind of no matter when sperm is there, we want sperm to be there before the egg is released. But even if you got the shot and did the IUI immediately, the outcomes of IUI aren't significantly different. So we trigger at an 18 just because once it's 18, you may release it at any time, Sally, but then again, you may not release it until it's 24 or 26 millimeters. So at least we have some control over it. So is there a difference in maturity between an 18 and a 20 millimeter follicle? Probably not. But generally speaking, most folks will trigger at about an 18. Let's see here. Looks like Mizabwise. That's a nice looking picture of the two of you there, but I'm not sure I'm pronouncing the name right, so my apologies. After 3 retrievals, my chronic infections are coming back, and I'm trying to prep my body for the first transfer. Any advice? Well, I got to say, I'm not 100% sure what you mean by chronic infections. There's some different kinds of things. Some people have chronic vaginitis. And chronic vaginal infections are one issue that really have to do with the microbiome, or the normal bacteria that live in the vagina. And so recurrent vaginal infections is something that we see very commonly in general gynecology. But maybe you're referring to the chronic endometritis, which is the chronic inflammation that happens in the endometrial lining. The chronic endometritis we typically treat with 2 weeks of doxycycline, which is an antibiotic pill that you take twice a day, actually, usually a capsule that you'll take twice a day. And I would certainly recommend, if that's what we're talking about, that we get that treated for you before you do your transfer because the outcomes are improved. And one treatment for chronic endometritis typically buys you about 6 months worth of anti-inflammation. And of course, we want to add some keto to that as an anti-inflammatory diet and the supplements that we talked about before for transfer. So good luck there. Thanks for being with us. Jenna Sutton is here on, hi Jenna, on Facebook, and she says, 48-year-old female using a donor egg. Okay, first transfer, there was a miscarriage at 7 weeks. In the second transfer, no pregnancy. Any suggestions for the next transfer? Well, so, I always say, my friends, it is an insult to injury to have to undergo IVF and to then have a miscarriage. It's just so wrong on so many levels. And gosh, I just wish that there was some way that we could prevent that. And maybe at some time in the future, they'll come up with some kind of technology. But the miscarriage most commonly happens because of a chromosomal issue. It happens because of the way sperm and egg come together from the moment of conception. Generally, it has to do with, it's not always an egg issue, but generally it's an egg issue in the way the sperm fertilizes the egg. It results in an embryo that's not chromosomally normal. And so as it starts to grow, at some point it comes to the realization that, well, wait a minute here, there's something wrong with me. I'm not going to be able to continue this process. And then the embryo stops growing. And that's usually what causes a miscarriage. That's the most common reason. And so, it's so unfortunate after going through the donor egg process to make, embryos and to have a transfer, to make it along to 7 weeks only to have that pregnancy. And gosh, I feel for you there. The second time, no pregnancy. And again, that is most probably due to a chromosomal issue. So in IVF terms, the reason that people tend not to get a positive pregnancy test is because of an embryo factor. We always want to look under every stone and make sure that we're not missing something. Like, well, could it be something about mom? More commonly, it's an embryo thing. So, Jenna, the kinds of things that I would look at there, number one, when was the cavity evaluated? So we want to know saline sonogram, hysteroscopy, make sure that there's not a polyp, that there's not a growth on the inside affecting you. Certainly a biopsy is reasonable for chronic endometritis. Is there endometriosis? Endometriosis is something that can stand in the way of both egg quality and of embryo transfer, and is one of the more common things that we find when folks are having an evaluation of why their transfers repeatedly failed. Endometriosis changes the way the brain talks to the uterus. It interferes with the communication. And if that's the situation, well, then we want to turn down the volume knob on that endometriosis, and we can do that with medication. It used to be that the only way we could test for endometriosis was through a laparoscopy, was through a surgery. Now there is a test, and you can read about it on the internet, called Receptiva DX, and that website is receptivadx.com. Receptiva tests for the presence of a protein in the uterine lining that is associated with endometriosis. Now, many folks with endometriosis have a pain syndrome. They have very painful periods. But silent endometriosis is a thing. People have it, and we diagnose it really every single day. If you're having surgery, we can try to treat that by excising it. If we diagnose it through the Receptiva test, then we treat it with medications. So I would, kind of want to look at those things, Jenna, just to make sure we have the I's dotted and the T's crossed. But hopefully, and of course, the supplements that we talked about, the supplement package for embryo transfer, I think is important. But hopefully that means that the next embryo that you have, which comes from a donor egg, where these donors have very stable DNA, they're all proven with children. God willing, hopefully that's going to be the one for you. And we will look forward to hearing that success story for sure. What labs determine? Looks like this comes from Nicole. You. What labs determine if you can do a fresh transfer versus frozen? That's a great question because, as many of you know, the fresh transfer is included in the price at CNY. So lots of folks come in with the hope of being able to do a fresh transfer, and that's fine. People do get pregnant from fresh transfers. I will tell you that the success rate with a frozen embryo transfer is probably a little bit higher just because your body has been in egg making mode, right? 100% you're in egg making mode. And sometimes you're in so much egg making mode that it makes getting pregnant or being in pregnancy mode a little bit harder. So the numbers that we would look at there, Nicole, would be one, the estradiol level, and two, the progesterone. So estradiol, typically, if it's above about a 3,000, then that usually means that the uterine lining is not going to be hospitable to a pregnancy. And so we really hate to see people put in, a beautiful, perfect embryo into a building that's on fire, because kind of that's what's happening in that scenario. Or a progesterone level that's above a 1.5, which is usually, in the last blood test before the retrieval. The progesterone controls the window of implantation, and as that number gets higher and goes above a 1.5, that window gets narrower and narrower and narrower until it's closed. So above about a 1.5, odds are very low that you will get pregnant with that fresh transfer. Now, I did have a good question today. Well, you said 1.5, but when I did my transfer, they told me they wanted it to be a 20. So here I am for my retrieval, and my progesterone is 3.5, and you're telling me I can't do it? Well, it needs to be at a 20. So what are you talking about? Well, it has to do with, you're absolutely right. So when we're supplementing you with progesterone after the transfer, we do like to see, CNY likes that number to be above a 20. And if it's not quite there, if it's a 15 or if it's a 12, then we will supplement you. We will increase the amount of typically progesterone and oil to give you in order to make that number higher. But it's the number that's obtained before that retrieval that tells us kind of what is the uterus doing when we're going to be putting the embryo back inside. And if that's above about a 1.5, Nicole, then we usually tell you fresh transfer is not a good idea because it probably won't work. Love Sir Finn says, I have had 3 failed frozen embryo transfers of PGT tested embryos. Should I attempt a fresh transfer? And sure, absolutely. I would absolutely really want to know that you got evaluated. Sometimes one of the things that happens, and I'll tell you that, gosh, this is frustrating to me, is that folks get into the flow of things here, and they'll do a transfer and maybe it doesn't work, and then they'll do another transfer and maybe it doesn't work, and then they call the global team back and they'll set up another transfer because they've got that embryo without talking to a provider. So by the time you've had 2 euploid transfers that have been unsuccessful, you need a consult with one of the providers because there's some workup involved. We need to make sure I's are dotted and T's are crossed there. So hopefully that's helpful. Oh, what else we have here? 31 years old. This comes from Bushra Ishak, 370. Hi, I am 31 and I have PCOS. I have high androgen and high insulin. What's the best fertility treatment to get pregnant? Well, so in that scenario, IVF is always going to be both the fastest path to pregnancy and the most reliable path to pregnancy. Now, unfortunately, it's also the most invasive because it requires doing a lot of things. And it's also, kind of the more expensive because the medications are not cheap. But what happens there is that we can treat all of those things. We can treat the way these things affect both egg quality and your production of eggs. And so IVF, Bushra, will give us really our highest and best odds for pregnancy in that situation. So now, the one other thing that I will mention there is that for folks with PCO, we typically err on the side. PCO often means that even though your ovaries may not be responding, to your own hormones, when we give you the medication, we know your ovaries are probably going to respond pretty well. So if that's the case, we don't want you to over-respond to become hyper stimulated. So for folks with PCOS, we tend to err on the side of going with lower doses of medication because quality of the eggs is more important than quantity. And this is something I really want to emphasize to everybody who's watching. If you're going to do IVF, I don't need you to have 50 eggs. I really don't, because when we have that many eggs from somebody who is kind of overstimulated, they're not quality eggs. And so you may get 50 eggs and 5 of them fertilized. And you say, oh my gosh, what happened here? Quality is more important than quantity. So we tend to go with lower doses and in order to keep you from being hyperstimulated. In fact, the evidence shows us that any number of eggs more than 15 retrieved from you in IVF, any number greater than 15 does not improve the outcomes. So hopefully that's a little information that is useful. Bree Bales, hi, Bree says, should I be rechecked for endometritis after having been on the antibiotics for 2 weeks? The answer is no. I would do the treatment, that 2 weeks of doxycycline for chronic endometritis, and that generally buys you about 6 months of being endometritis free. Now, sometimes we will, for one reason or another, end up testing people again, and they still have it. And what happens there is that it's sometimes hard to completely quell chronic inflammation. And you may know that from folks who have arthritis or who have other types of pain syndromes, that when you've got a chronic inflammatory process, it's not that you can take a couple of pills and suddenly it's gone, it's cured. It oftentimes does come back. But that's also why we add the immune protocols, because we're trying to suppress the inflammation, why we recommend the keto diet, because we're trying to suppress the inflammation and trying to keep the immune system from standing in the way of us being able to get pregnant. So let's see, it's about getting close to 10 minutes to the top of the hour. We got about 10 minutes or so left. Glad that everybody is with me here on our Tuesday afternoon Fertility with Fink and Friends, live via internet from Colorado Springs. Krista here on the Facebook side says, what criteria should I use to decide between transferring 1 or 2 high-quality PGT tested embryos? The answer to that is you transfer 1. No ifs, ands, or buts. My opinion and the ASRM guidelines are that if you have a tested embryo, we want you to have 1 safe pregnancy at a time. Again, with a tested embryo, your odds are the highest for getting pregnant. And putting 2 embryos in does increase your probability of a positive pregnancy test, but it does not increase the probability of a live birth. What that means is that it increases the chance of pregnancy loss. And oh my heavens, that's something we really want to avoid. Everybody knows somebody who's had twins. Twins are cute. You can dress them up and they grow up together. Everybody knows twins and sometimes even triplets. But the fact of the matter is that is a high-risk pregnancy. There is a significant increase in the risk for severe preterm delivery that results in prolonged NICU stays and innumerable medical complications and problems such as cerebral palsy, or even being born too early to be able to sustain life, rupturing membranes at 18 weeks, severe preterm labor at 20 weeks. So, gosh, I would say the answer there, Krista, is 100% with a euploid embryo, 1 embryo. Morgan says, I was prescribed Neupogen and Lovenox for my first FET. No fail, no clotting disorder, no miscarriage in the past. I was wondering if it was normal to be on Neupogen and Lovenox for the first embryo transfer. Morgan, that's a good question, and I think a lot of that depends on who you talk to. In my opinion, I would say, first time around, I usually go with an immune protocol level 2. Now, you could ask the same question to my colleague, Dr. Kiltz, and Dr. Kiltz will tell you there's no reason anybody should be on immune protocol 2, because if you wanted immune protocol 2, you could be doing something like that at home. You're here for a reason, so we want to put every chance that we have towards your transfer in order to get you pregnant. So, given that, I think it's not abnormal to be on immune protocol level 3, which includes Neupogen and Lovenox. Neupogen is a medication that fires up your white blood cells, so your white blood cell count goes high in order to help combat some of the immune things that can keep us from getting pregnant, while Lovenox is a blood thinner. I don't have any issue with Lovenox. Some people don't want to take it, so if that were the case, I'd say, well, then you can just use a baby aspirin if you would prefer. But at the end of the day, it's a matter of preference, and certainly that is something that you can discuss with your provider. There's some people who say, I want everything I can get to try to make this work because I want to do it one time. There is some group of people who those medications will help. And we may not know who you are based on the testing that you've been able to do. We may have some situation that we may not even be able to test for. And if that's the case, then those medicines are helping you. Meanwhile, we're treating everyone with them. So are they helping everyone? Well, we know that they're not hurting everyone. So they may be helping. And if they might help, then it might just be worthwhile. And I suspect that that's what the choice was with you, Morgan, there when they wrote your protocol for you. Emptiness dancing is asking, do I recommend taking birth control or estrogen and progesterone before starting an IVF cycle? Well, doing that is what's called priming. So we can prime you with estrogen and progesterone. Estrogen is the language that the ovaries speak. So by taking some estrogen, we're increasing the creation of blood vessels in the ovaries, and we're balancing that out with some progesterone. So that's the reason for estrogen and progesterone. Birth control is kind of just a convenient way to take estrogen and progesterone all together in one pill. But some practices will also use birth control to try to batch their cycles, so that CNY doesn't do this. We don't batch cycles, but batching means in practices that may only have an embryologist for a couple of weeks out of the month, or may only have anesthesia providers for a limited period of time. If you batch the cycles, then that means all your transfers are going to be in 1 month, 1 week of the month. All your retrievals are going to be in 1 week of the month. And the rest of the time is kind of monitoring time. That's how they batch cycles. At CNY, we're working every single day because of the volume of patients we see, so there's no reason to do that. But sometimes we'll put people on birth control to try to quiet down the ovaries if they're at the beginning of a cycle. Sometimes we'll do it to try to synchronize the eggs in the ovary, because if they're all different sizes, then helping them to be the same size may help them to grow at a similar pace, so that when it comes time to retrieve them, they're all kind of basically the same. Let's see here. A LinkedIn user says, I like your mullet. Well, thank you. All right. So this is my, I'm Randy Ray Cyrus. And that's what, Randy Ray, CNY Fertility. How do you like that? Yeah. I'm just getting all retro here. And really the reason is so that when I wear my surgical hat, that my curls hang out the back, so that I can lament what it was like when my hairline was was a little bit lower. But thank you, I appreciate it. I'm sporting the mullet. Here we go. Let's see, we have time for a couple more questions here. M Kid says, so many ladies with unexplained infertility for years are getting pregnant with Mounjaro or Ozempic. Do you know the science on that? The answer is yeah, that's a good question. It's because it causes weight loss. So the fat cells in our body are the cells that process our estrogen hormones. Really, testosterone is converted to estrogen in those fat cells. And so we tend to, and honestly, the classic thought that comes to mind are folks who may be heavier who have polycystic ovarian syndrome. Well, if we can cause even a 10% loss in weight, the pregnancy rate goes up. So, yes, weight loss will help. Think about it this way: it makes for a healthier baby house, better baby house. So, yep, absolutely. I have a pretty good experience with semaglutide, and that is a service that we offer through Cheyenne Mountain Gynecology, which is my other practice here in Colorado Springs. And so you can reach out to us there and we can talk about medical weight loss. Ozempic is semaglutide, Mounjaro is another type of medication in that same class. And it does a couple of different things. They cause you to be fuller faster. They slow down the stomach's emptying time, so you retain a fullness. It keeps your insulin levels a little higher so that you're burning off your fat. So it's working at the level of the brain and at the level of the pancreas. These are called GLP-1 agonists, and are very successful. So hopefully that's helpful information there. Let's see, we've got, hi, Cindy, Alaska. Bungster said, just found out my partner's DNA fragmentation is only 15%. We know he's only got, he's got very low morphology. Could that have been the cause of my 2 naturally conceived miscarriages? Well, again, that's hard to say because it's hard to know exactly what causes a miscarriage. It's usually a chromosomal issue. More commonly with male factor infertility, we can we see a situation where the eggs themselves just don't fertilize in the lab. That low morphology is not considered to be a cause of infertility per se, but rather an association with those who have fertility issues or subfertility. So is that the cause of a miscarriage? Well, I would say in that situation, there is a particular supplement that I recommend for sperm. There are several supplements that go into sperm quality, but there's one particular vitamin that kind of includes all of them, so you end up just taking one pill. I wish there was the same thing for women. In fact, you know what? If I ever get into the nutraceutical business, I might try to manufacture one pill that you could take that just encompassed all of the CoQ10 and all of the melatonin and the vitamin D and all the other things that go into that biochemistry of egg quality. Wouldn't that be a nice thing? Let's see here. Can I still use my eggs with an AMH of 0.16? So that comes from BJ Pumping. And I will tell you that, the AMH really only tells us about how we expect that you might respond to IVF medication. It doesn't say anything about your ability to get pregnant on your own necessarily, or even anything about egg quality. So the answer is yes. I've seen plenty of folks with an AMH of 0.16 who get an egg, make an embryo, and get themselves pregnant. But again, what I do is I would want to control. We can't control how much ovarian reserve we have left, because that's based on the clock. But what we can control is the quality of those eggs. We have the ability potentially to control that by cleaning up our acts and by taking the supplements that are recommended to be able to affect egg quality. So yeah, I would say, BJ, probably so. Well, it looks like we are about to have to wrap it up here. One other quick question. Any other thoughts? And this comes from my friend Lauren in Miami. Any other thoughts on high thyroid antibodies and infertility? Yes. So anti-thyroid antibodies show that your body has created a response against your own thyroid gland, which means that there's absolutely some inflammatory component to your fertility. It also means that your thyroid may not be functioning optimally. And so that's why we always want to check it. We want that thyroid level to be between 0.5 and 2.5 on the TSH. So usually for folks who have those anti-thyroid antibodies, Hashimoto's thyroiditis, we call that, I recommend immune protocol 3. Infertility is not the end of your story. It is only one chapter, and we are certainly in the business and excited about helping you write that next chapter. So thank you all for being here with me today. We'll see you next Tuesday at 4 o'clock Mountain Time. Until then, I'm Dr. Randy Fink, CNY Fertility, Colorado. God bless you all. Good night and best of luck. So long.